Good evening, everybody. It's Usha Chauhan. Thank you very much for joining the webinar this evening and taking time out from your busy schedule. I'd like to thank Crohn's and Colitis Canada for organizing this, especially Emily for organizing this session. And I'd also like to thank Dr. Neeraj Narula, who is going to be presenting. I will be moderating the session and hoping that everything is going to go very well for us today to advance our presentation. I just want to let you know a little bit about CANIBD. So CANIBD is sponsoring the event this evening. CANIBD is a community of practice of nurses across Canada working in fields of IBD. Our vision is to ensure people of all ages living with IBD in Canada receive high quality clinical nursing care within a multidisciplinary team. The community of practice, it's a community of practice within CSGNA, which is the Canadian Association of Gastroenterology Nurses and Associates, and it's supported by Crohn's Colitis Canada. CANIBD is also committed to improving the quality of care of people living with IBD and providing mentorship and learning opportunities to IBD nurses across Canada. It's creating an opportunity for networking and sharing of best practices, developing and adopting nursing guidelines as well as standards of IBD nursing in Canada, and elevating the profile of IBD nursing in Canada. We will be having our first conference this year again in November, so we're hoping that you can join us at the conference. So today's webinar is going to be presented by Dr. Neeraj Narula. I have an opportunity to work closely with Dr. Narula. Dr. Narula is an assistant professor of medicine at McMaster University, and he's the director of the IBD clinic and is a staff gastroenterologist at Hamilton Health Sciences. He has completed the present Levson Advanced IBD Fellowship at Mount Sinai Medical Center in New York in 2015. And believe it or not, he started off as a chartered accountant at the University of Waterloo and has worked at Ernst & Young and KPMG. He subsequently attended medical school at the University of Alberta and has completed his internal medicine residency at McMaster Medical Center. I had also opportunity to work with him during his residency as well. He's completed his Masters of Public Health at Howard T.H. Chan School of Public Health, and his research interests are predominantly in clinical epidemiology, nutrition, and pharmaceutical clinical trials in IBD. So the evening presentation is also sponsored by AbbVie. So thank you, AbbVie, for sponsoring this event today. Today's event, it's going to be interactive, and there's going to be a couple of times during the presentation that Dr. Narula will be asking you asking questions, and the phone lines, your phone lines will be unmuted, so you can ask questions in person, or if you want, you can type it into the chat as you please. So I'm going to pass it along to Dr. Narula to carry on now.
Hello, everyone. Thank you, Usha, for the introduction, and thank you to CANIBD for inviting me to speak to you guys this evening. It's a pleasure for me to be speaking to you guys, and I'm happy to be invited back to speaking to the CANIBD group. Now, this session that I'll be presenting this evening, it's part of the Total Care in IBD sessions that we designed earlier this year, actually, and this was a series of lectures that were basically put together by 4 faculty, including myself. that were designed to look around hot topics in IBD and kind of structure education around cases. And it was actually more designed to be a choose-your-own-adventure type format where there's several decision points that come up along the case. And at that point, the crowd who's attending would decide which way they want to go with the case, and then we'd kind of go down that pathway. Now, it'll be a little bit more challenging to do it in this format, but there'll be a couple of opportunities where I'll open up some discussion to the group, and then we can kind of decide how to proceed. So these are the disclosures from all the faculty members who participated in the Total Care for IBD series, and these are the CANIBD's roles that will be covered in this session. And this is actually an accredited activity. We had this accredited by the Canadian Association of Gastroenterology, so you can claim credits as well from your institution for education this evening. So program overview, and as I mentioned, this is actually based on 4 different cases. This evening we'll be looking at case 3, and the theme around case 3 is treatment optimization and secondary loss of response in Crohn's disease. And these learning objectives are actually objectives for the program as a whole. So if you do attend other Total Care and IBD sessions, kind of give you an idea of what to potentially expect. And now focusing on case 3, we'll be looking and discussing the benefit of early optimization in treatment. We'll discuss the role of TDM and monitoring patients and making treatment decisions. We'll speak as to how you can interpret TDM results with regards to drug levels and antibody concentrations, particularly when you're looking at someone who has a secondary loss of response. And then we'll decide and discuss when it's appropriate to try to either optimize your treatment or when it's appropriate to try to switch within class or switch out of class altogether. So we'll start with a case of Mary, who's a young female, 22, and has a history of ileocolonic Crohn's disease when she presented with a perianal fistula and received steroids, but because of the perianal fistula, got put on anti-TNF therapy, in this case, adalimumab as a monotherapy, as she did not want to use azathioprine, and eventually was quickly dose escalated to 40 milligram weekly and did well on this dose, achieving clinical, biochemical, and endoscopic remission with no more further drainage of her fistula. And she presents 1 year after being on treatment and complains that her symptoms have returned, and she has a fecal calprotectin scent, and that's come back elevated at 600. So the first decision point is Mary experiencing a secondary loss of response? And this one I won't bother opening to the group. I think it's pretty clear that this patient is experiencing a secondary loss of response. So I'll ask Emily to click on yes, if I can't click it. Yep, there we go. And basically the point here is to really just discuss what are the definitions of primary and secondary loss of response. And these definitions vary a little bit, but for the purposes of the literature, and if you look at studies and studies are looking and defining people who are primary non-response and secondary loss of response, they tend to use certain definitions which remain reasonably consistent. A primary non-responder is basically someone who hasn't achieved any clinical response after they've received complete induction. And the secondary loss of response is thought to be someone who does achieve initial therapeutic benefit and then subsequently lose a response. It may be that they've achieved that therapeutic benefit after induction, and then as soon as they went on to maintenance, they lost response, or maybe that they did well after induction and were on maintenance for quite a while, and then sometime down the line, they subsequently lost response. And if someone's coming to you with symptoms that are sounding like they're a flare, you want to obviously confirm that you're dealing objectively with a flare and do some investigations, including rule out infections and so on, to just confirm that you're actually dealing with a flare before you define this patient and to start treating them as a secondary loss of response. So there's a number of variables that affect the clearance of TNF alpha, and this is the reason why some patients will experience a secondary loss of response where some don't. And you guys are probably familiar with most of these. We certainly see that when you use an immunomodulator in combination with biologic therapy, it helps reduce antibody formation and as a result helps keep drug concentrations up and lower drug clearance. And obviously, if you do form antibodies, that ends up increasing drug clearance. People who are male are thought to have higher drug clearance. People who have higher baseline levels of inflammation, which can be measured through CRP, or if you have the ability to measure TNF-alpha in the serum, those people also have higher drug clearance. Patients with higher BMI are also thought to have higher drug clearance, and low serum albumin has also been shown to be associated with increase in drug clearance. So TDM is something that probably all of you have ordered and are becoming more and more familiar and comfortable with. And it's something that I think a lot of the gastroenterologists like to also use to help guide what is the best intervention next. And interestingly enough, when you look at the literature, and this is from the AGA technical review where Niels van de Castile basically summarized all the literature out there on TDM, and he concluded that there's actually, not clear evidence that suggests that this approach is superior to then just empirically escalating the dose. There may be other reasons to use it, for instance, cost effectiveness. But if you were looking at purely clinical outcomes, it doesn't seem like your clinical outcomes are necessarily improved if you use TDM to guide your management versus if you were to just empirically dose escalate anyone who showed up with a secondary loss of response. That was a little bit different than the recommendations that came from ECHO back in 2016. And at that time, they did recommend that patients who have a confirmed secondary loss of response to anti-TNF should be first managed by dose optimizing, and you can use TDM where available to help guide this optimization strategy. So this is an algorithm that probably everyone who manages IBD is now using when trying to decide how to interpret TDM. And after you've confirmed that this patient has objective secondary loss of response that you think is due to reactivation of their IBD, you're going to measure drug level. And it can basically go one of two ways. They either have no drug detectable, or they have drug detectable. We'll look on the right first there, and patients who have drug detectable, you'll want to get a sense of how high is their drug level. Is their drug level kind of low and it's less than what you think would be therapeutic? In that case, you're going to end up escalating their dose, or is it pretty high and you don't think that they're going to get much more benefit from pushing their dose beyond that, in which case you might be thinking even switching them out of class altogether. The thought being that these patients seeming like they have enough anti-TNF on board, and despite that, they are having still ongoing inflammation. So perhaps if their mechanism of inflammation has changed, but it's not predominantly mediated by TNF-alpha anymore. The other route is patients who do not have drug detectable. And in that case, you'll see a subsequent test where they measure whether antibodies are present or not. Certainly, if someone does not have antibodies present, that's easily a decision to make there that you want to escalate their dose. If someone does have drug antibodies present, however, you'll look at the titer of the antibody, and you can make a treatment decision based on that. And I'll get into that in a bit. But basically, someone who has a low titer, you can sometimes overcome the low titer, whereas sometimes if you have a high titer, those are quite difficult to overcome. And in that case, you may want to switch them to a different anti-TNF. It seems like this patient probably does respond to blocking TNF-alpha, and they just lost response to this particular drug. But if you were to switch them to another anti-TNF, they tend to do well. This is some data which is basically summarizing anti-TNF data from either real-world cohorts as well as from different clinical trials which have been using anti-TNF for IBD. And you can see from all of these different experiences that basically in patients who've had secondary loss of response, just empirically escalating the dose does result in short-term response in about 60 to 70% of patients, which is pretty good. 2/3 of patients respond to that dose escalation when they lose response. There's a couple of studies I'm going to show you, and these are both retrospective studies, and I think they're thought-provoking for sure. The first part of this, first study I'm going to show you, I want you to focus on the middle here. This is a retrospective study that comes from UPenn. And they basically looked at their patients who had been on anti-TNF therapy, were either primary or secondary non-responders, and what happened to them when they got treated with a second anti-TNF. So if you look at the middle group here, the patients who had a secondary non-response and ended up going on a second anti-TNF, you can see the very, very low number of patients here. 8% were a primary non-response to their second anti-TNF, suggesting that most of these patients actually did respond. So you can see these people who previously demonstrated a secondary non-response to an anti-TNF. When you put them on that second anti-TNF, they most often do well. Now, the thought-provoking part of this study is this column over here, the primary non-responders. And these primary non-responders, conventionally we think that if you're a primary non-response to an anti-TNF, maybe we don't go to a second anti-TNF in you. But you can see at their retrospective experience, when they look at those patients who were primary non-responders and received a second anti-TNF, they found 53% of these patients were a primary non-responder to their second anti-TNF, suggesting that almost 50% of patients actually had a response to their second anti-TNF, despite not having a response to their first anti-TNF. So their conclusions were that if you are a primary non-responder to your first anti-TNF, it shouldn't necessarily preclude you using anti-TNF in the future. Now, this study, it's difficult to make firm conclusions because, as I mentioned, it's retrospective. A lot of these patients don't have things like drug levels, PDM, that type of stuff available to try to figure out, how they actually were defined as a secondary non-responder. Did they have a dose optimization prior to being switched, and so on. So a little bit limited in terms of what we can draw from the study, but again, a little bit interesting as well. This is another study that I think comes from Amsterdam. And again, they looked at this question of what happens to patients who are treated with a second anti-TNF after they failed their first one. And you can see in those patients who basically had no response at all, which is about half of their group, to their first anti-TNF, they basically, when they got a second anti-TNF, about 44% of these patients achieved remission, showing basically similar numbers to what I showed you in that last study. These patients who were partial responders, again, after they get their second anti-TNF, 60% or almost 60% of these patients achieved remission. So, again, opening the idea that perhaps if you were a primary non-responder to your first anti-TNF, perhaps we shouldn't be so quick to dismiss a second anti-TNF in this patient cohort. Okay, so the next question that comes up is, what is the threshold? I mentioned when I showed you the algorithm that you want to be looking at your drug level, and if you thought it's above what you would define as a therapeutic range, perhaps there's no point in pushing that drug anymore. And the question comes up is, what is that therapeutic range? And that's a little bit difficult to inform because the evidence is, 1, quite mixed, 2, poor quality, and 3, we only have a range of numbers for a couple of the biologics that we actually use. You can see here that these are studies which have been done using infliximab as well as adalimumab, and you can see the numbers are a little bit variable. For infliximab, you're seeing ranges here between 0.5 and 15 as the recommended cutoffs, and for adalimumab, you're seeing recommendations between 6 and up to 15. So again, it's very difficult to just kind of look at this literature and try to come up with a magic number. The issue is there's different assays that are used in different parts of the world. Some places are using ELISAs. Even between different ELISAs, there can be a little bit of variability. Some are using HMSA lab technique, and then the outcomes that are being looked at are sometimes different. These studies are all looking specifically at mucosal healing, but when you look at the data as a whole, you'll see sometimes they're just looking at clinical symptoms, sometimes they're looking at histologic improvement, and when you have a variability of the outcomes you're looking at, it's also going to affect the target drug level. I'm going to show you a couple of studies just to illustrate the point that I was making. So this is a study that comes from Boston, from Adam Shafit's group. And what they looked at here was infliximab and the concentrations. And you can see how the concentration that you target might be a bit variable depending on the outcome you're trying to target. So if you look at the left first, you'll see they're looking at patients who achieve biologic remission. And then you can see that basically as soon as you hit that second quartile, and any time above that second quartile, you have a very high number of patients who are in biologic remission. And to get to the second quartile, you need to have the level above 3. But if we're going to start looking at more optimistic outcomes that we want to achieve for our patients with endoscopic healing or histologic healing, you can see that the quartile cutoff here is a bit higher. And, for instance, to have 55% of your patients having histologic healing, their level had to be a bit higher than just to simply get into biologic remission and just have symptom improvement. This is similarly shown for adalimumab, and you can see again, this is data from the same group where they basically demonstrated again that the levels that you need to achieve biologic remission seem to be a little bit less than the levels that were needed to achieve endoscopic and histologic remission. This is a study from Mount Sinai, Toronto, and what they did in the study was they basically looked at their patients who were on adalimumab and achieved endoscopic remission versus not. And you can see when they looked at their patients who were in clinical and endoscopic remission, the median adalimumab level was 13, whereas those patients who had not achieved this combined endpoint had a median level of 4.8. So again, we're seeing quite a difference in the target level for patients who ended up doing well versus not. This is an algorithm that was proposed by Richard Fedorik out of the U of A for adalimumab specifically. Now, I'll give you the caveat that this algorithm is not based on strong evidence by any means, and it's probably more expert opinion. But basically what they suggested is that if once you confirm that disease is present and you do a TDM, and this is for adalimumab specifically, like I mentioned, if the drug concentration is low, and they propose less than 3 as low, then certainly dose escalation is the most appropriate option here. If it's somewhere between 3 and 20, then there's things you could consider. Well, I think to the next slide. There's different things you can consider that could include dose escalation. You may want to re-induce them. You may want to add steroids. You may consider combination therapy. So different things, but certainly look at some method of optimizing their treatment. And they propose that a level greater than 20 is probably high enough that if they were higher than that, you're probably not going to get much further benefit from pushing the adalimumab anymore. At that time, you may want to consider switching their biologic. So we'll go back to our case, Mary, and we decided to do TDM now because we think this will help guide our treatment decision. So maybe we'll open it up at this point to the group, and I'll take any questions on so far the things that I've discussed, as well as we can get some sense of where the group wants to go with this. As I mentioned, we can kind of choose our own adventure here. So if there's particular situations that you feel like you struggle, let's say low titer antibody. I think I'm unmuted now. I still don't know if I can hear anyone else. Okay, I think there may be some issue to unmute everyone. So maybe what we'll do is I'll just proceed down the algorithm. I think you guys can send your questions in the chat box, and certainly I can take those questions. Maybe I'll pause for a minute now, just in case there's any questions that are coming in. Okay, the first question that's come in is, what do I consider as a low level of antibodies, and what would I consider a high level that cannot be overcome? I will address that by going through that exact scenario. Okay, so let me see if I can actually go back. Okay, so to get to a low titer of antibodies, we're going to say that the drug level was undetectable, and then there was a low titer of antibodies present. Let's see, I think another question's coming in. So the second question that's come in, maybe I'll answer this first question by going through the scenario first, and then I'll take on the second question. So, just to show you once again, we have the algorithm that I previously showed you. So to get to the low titer antibody, that was near the end here. So we have anti-drug antibodies present. I told you low titer, and then we'll go through what your options are at this point. So the first question is, what is a low titer? This threshold we use, so the number you see there is 9 or 130, which is the number that would be based on the Dynacare assay that we commonly are using in Canada. The 9 is from the HMSA Prometheus assay. Why do we use this number? Well, there's a couple of reasons. One is this study by Niels van der Kasteel, where he was looking at patients who form antibodies to infliximab. And what he found in this study is that if you had antibody threshold above 9, again using the Prometheus assay, which correlates to 130 in the assay that we use, then it was very unlikely that you're going to be able to be overcoming this by just increasing their drug, which is what the intervention is that was performed in the study with all patients who ended up having a loss of response. There's a couple of other centers which have also reported on their experience. Maybe I'll show you that in the next slide. This is a study where they actually looked at patients who were on 40 milligram weekly of adalimumab and had a secondary loss of response. And then they ended up having escalation to 80 weekly. And you can see here that after 5 weeks, a lot of these patients were able to recapture response. Almost 60% of them recaptured response. You can see the CRP dropped, and CRP went from 18 to 5 or 4 or so, 4 or 5 after 5 weeks. And a lot of these patients had a reduction in the CDAI. So you can see that even escalating patients who are already on 40 weekly, you can still get some bang for your buck if they do subsequently experience a secondary loss of response. This study is a study where they basically looked at different interventions that you could perform in someone who has a low titer of antibody. So you can see in this study what they did is different physicians did different things. It was retrospective. Some of them added just an immunomodulator on board. Some of them tried to push the anti-TNF. And you can see on the right there, there's different rates of success. So there were 7 patients where methotrexate was added when they had a low titer antibody present, and they were able to overcome it in 86% of the cases. There was 10 cases where azathioprine was added. In 70% of cases, they were able to overcome it. In 22 cases, patients only had their anti-TNF optimized. You can see it wasn't as successful, but 1/3 of cases were able to overcome it. And optimized immunosuppressant means that they basically just have their dose of azathioprine increase, for instance. So what is the best approach? I can't tell you there's a best approach, but my approach tends to be a combination of both adding an immunomodulator as well as pushing their anti-TNF dose. And I'll usually try to do that combination and repeat their TDM a couple times after a couple of doses and see how it's looking, see if I'm getting some success here. And once I get those antibodies out of the way and I'm happy with my drug level, I may consider dropping their immunosuppressant at that time. Okay, so maybe I'll try to take on the other questions that have come on before we go back to this case. Let's see. When do you go to dose escalation and when do you move out of class with a loss of response? So again, if we go back to the algorithm, it nicely illustrates that, but I'll also walk you through that part of it. So let me just get back here. This is the algorithm. So it says, when do you go to dose escalation and when do you move out of class? So the dose escalation, basically, I would always do dose escalation for someone who does not have enough drug present. What is enough drug? Well, that's based on your drug level and what your drug level target is. For infliximab, that level is somewhere between 3 and 10. For adalimumab, that level is probably somewhere between 5 and 20. So if someone is, less than 10 for infliximab or less than 20 for adalimumab, that's someone I'm going to be considering a dose escalation for if they're having a secondary loss of response. For someone, when do I move out of class? When I move out of class is when we're on this part of the algorithm. So that's the person who has high levels of drug, that are higher than what I would think they need. So for instance, if someone had an adalimumab level of 24 or an infliximab level of 14, those are higher than the thresholds that I proposed to you earlier. So that's someone that I don't feel I'm going to probably get too much bang for my buck from either pushing their anti-TNF anymore or even putting them on a second anti-TNF, because I think this person may not be having their mechanism of inflammation predominantly driven by TNF alpha at this point. And I'll see the next question here. What is the standard algorithm for TDM in my practice? It's basically this, and I think this is not just for me, but I think this is the case for really most GIs who manage patients who have a secondary loss of response to their biologics. Okay, next question. I think this is the last question. It says, what do I consider as a low level of antibodies, and when do I think that it can't be overcome? So I did answer that in my last, or in the first question that I went through. Is this 130 is a magic number that I tend to use. And 130 is not like a hard cutoff. You know, I've had patients who've had 140 and I think 150 even before who will still try to overcome it, but certainly it gives you a sense of what you're potentially dealing with. You know, the patient who has 1,000, I'm not bothering with these strategies. But the patient who has somewhere in the low 100s or even lower than that, that's someone I'm happy to try one of these strategies to try to overcome it before I abandon that therapy. Okay, so we'll go back to the case. We walked through this part of the case already. Hold on. So this is back to Mary, and Mary, like I mentioned, had a low titer of antibodies. So in her case, we only increased her Humira to 80 weekly. Again, she was very resistant to starting azathioprine, but luckily she was able to achieve adequate response with just that therapy alone, and was maintained on this dose for 3 months. So we repeated her TDM down the line. We ended up actually putting her dose down again because she ended up having quite a high level and was feeling great. So we wanted to try going back down to 40 weekly, which we did, and she seems to do reasonably well on that again. So just to wrap up this part of the talk, certainly when you have a patient who has a loss of response to treatment, you want to confirm that you're actually dealing with a loss of response because of reactivation of their disease. So using objective markers, things like fecal calprotectin, CRP, or imaging or endoscopic assessment. And really, we don't have that many biologics yet. Certainly there's more the more we have now than we had 3 years ago, and I think we're continuing to expect more and more coming in the coming years. But at this point, we still try hard to optimize first-line biologic therapy before changing treatments, because we know that once you get on that second or third biologic, these patients are quickly running out of options. This is a little bit different thinking than the rheumatologists or rheumatology colleagues feel, where they have more than 10 options for rheumatoid arthritis, for instance, so they don't feel as strongly about things like TDM and optimizing first-line treatment. But for IBD, we still certainly feel that this is the case, and we see very good outcomes in these patients who we do optimize treatment for. So I think it's still worthwhile. And then for patients who have low titer antibodies, it is recommended to dose optimize or add an immunomodulator on board. And I showed you what kind of outcomes you can expect from those types of strategies. So that's basically the end of the program. And like I mentioned, this is a kind of a choose your own adventure. So if you guys do have questions or want me to try to explore different antibody results or different TDM results, we can do that. I see some more questions coming in, so why don't I have a look at that? Okay, so the next question that came in says, regarding TDM, is there ever a level that's too high or is there ever too much drug? Great question. I can't answer that question with the data that's being shown to you on this program, but I can speak to you about studies which have tried to look at that. There's really only one study that's tried to look at that question. That was a study that was presented by Tomer Greener from Mount Sinai, Toronto, at DW last year. And what they did is they looked at, this is a retrospective study where they looked at patients who had infliximab levels available, and they put them into one of two groups, what they defined as a high drug level, basically a level of 15 or more, or a level of less than 15. And they looked at all the clinical data available in the patient chart, as well as the Mount Sinai Hospital record system, to try to look at what happened to these patients in the 3 months before or the 3 months after they had their TDM done, with their main outcomes of interest looking at adverse events as a whole, but looking at secondary outcomes of interest of infusion reactions as well as of infections. And interestingly enough, they actually found that there was a higher rate of adverse events in the group that had levels less than 15 compared to the group that was greater than 15. And they actually found significantly more infusion reactions as well as significantly more infection in that group. So I was very interested to see that result. I think, it certainly makes sense that you're going to get more infusion reactions in people who have lower drug levels, but it was quite reassuring, I think, to see that there wasn't a higher rate of infection in the group that had higher drug levels present. So, at this time, I don't think we feel that there is something as too high a drug level, and if you hit a certain drug level, you should try to be backing off. There may be other reasons for it beyond safety, whether that's financial or other considerations like that, or if someone's, having an infusion every 4 weeks and it's really impairing to their lifestyle and they'd rather have it less frequently, for instance. But from a pure safety standpoint, the data that we do have available to us doesn't suggest that there is a concern with having a drug level that's too high. Okay, I'll go to the next question. Next question says, is there evidence to support adding azathioprine with Humira to increase the drug level? I presume this question is referring to the setting of someone who has a secondary loss of response to Humira or an TNF, and the answer would be yes. And that was shown in this study, actually. Let me just go back to that slide. So you can see this study, they actually looked at both infliximab and adalimumab and the outcomes that were achieved in these patients when these strategies were taken. So I would say that this strategy of adding an immunomodulator and optimizing the anti-TNF applies for both adalimumab as well as infliximab. Next question says, do I ever reduce the biologic dose in the case of a high TDM? And I would say my answer to that is no, and that my practice has changed since I came across those results from that Mount Sinai study that I discussed with you earlier. So like I mentioned, for the purposes of safety, I am not concerned that a high level leads to unsafe outcomes, but there may be other reasons why I may reduce the dose. The one patient I can think of was someone who was getting their dose every 4 weeks, and their level was, I think, 25 of infliximab. So that patient we went to every 6 weeks, and that was mainly just because of patient convenience. But from a pure safety standpoint, we haven't seen any data that suggests higher levels are associated with more adverse events. All right, that's the last question that I received. I can certainly ask for any more questions. Okay, it does not seem like there's any more questions. So if that's the case, then I think we can wrap up the webinar program for this evening. Thank you, everyone, for attending. Lucia, I'm not sure if you have any final words.
Oh, difficulty unmuting myself. Sorry. Thank you very much for attending. And if there's no questions, we look forward to seeing you at our annual meeting in November. And if you still have questions, please feel free to email them to me or Emily, and we will make sure Dr. Narula gets them. In addition, you will also be getting a survey to evaluate the webinar today. Please make sure that you complete the survey so that we can then organize our future webinars. Thank you very much, everyone, for attending. Good night.